I want to just call attention to some of our supporters today. First of all, I want to thank Dean Krishnan of the Hines College. He has been a stellar supporter of this series. And Sri Mehta, would you raise your hand? He has been our tech person. He has been creating flyers, publicity materials for us on a regular basis and helping us get the word out. So we want to thank Sri. Eva Jean, our program coordinator, as many of you know, carries out the day-to-day work of CAUSE, and she is the program coordinator for this series and for the CAUSE program more generally. Over the years, we have gained substantial support. By the way, I have to acknowledge the Giant Eagle Foundation and the Giant Eagle Corporation, because they fund my professorship, Giant Eagle Professor of History and Social Justice, okay? So I just want to say thank you to all of those people, and also to our administrators at Carnegie Mellon. We have been fortunate enough to have the dean, the provost, the president, and our department head in history support this program over many years. This year, this particular series is special because it is connected with 3-year A.W. Mellon funded project on reparations. And we are hard at work. And this series, by the way, is entitled Reparations in African American Life. And the first talk we had was on faith-based initiatives around reparations. And today you're going to hear Weiner talking about healthcare in Pittsburgh. The people connected with what we call the Crafting Democratic Futures Project, I want to acknowledge them because they have been working over the past 2 years, almost past 2 years on this project, and I want to call their names. We have 2 community fellows, Carla Young and Patricia Mitchell. Raise your hand. And we have 3 research assistants, Michael White, he's not here, Stacy Akan, not here, but Arko Dasgupta is here. Some of these people are in virtual, okay? We're coming to the sort of centerpiece in a real way of our reparation project. It's something we call the Community Advisory Committee. And I'm delighted to say that Esther Bush, our former CEO and president of the Pittsburgh, of Greater Pittsburgh, is here. She's here with us. So thank you for coming tonight. In person, I'm really amazed but grateful. Sam Black at the Hines History Center, Charlene Fogel Barnett at the Carnegie Museum of Art, and Ralph Proctor at CCAC. These are people who are on that committee. And by the way, we have 2 co-chairs of that committee. Waverly Duck, a sociologist, formerly at Pittsburgh, now at Santa Barbara in California, and Ben Houston, who was the original director of the Cause Oral History Project here at Carnegie Mellon. But he is now in the UK at the University, Newcastle University. Finally, I want to just acknowledge that we do have, CAUSE has an advisory board. And I think I mentioned this the last time. These other projects have created so many meetings that we are yet to call our meeting for this year. But CAUSE advisory board include people like Eric Anderson, Nico Slate, Etta Fields Black, and other people connected with the library. So I want to thank them. But most of all, I just want to thank the audience for being here. You are the major reason that we carry out the speaker series and the activities that we do in the Center for African American Urban Studies, because we believe strongly that scholarship that remains behind the walls of the university is not very helpful scholarship. And so we want to make that connection between scholarship and social change. scholarship and community development. And so we open this series and have historically opened this series to the broader community. And we've been grateful that people from all walks of life have visited these talks. So without further delay, let me now turn to introducing our speaker, Professor Gabriel Weiner. Professor Weiner is an assistant professor of history at the University of Chicago. Before arriving at the University of Chicago, he was a visiting scholar at the American Academy of Arts and Sciences. He received his PhD in history from Yale University. Dr. Weiner is a specialist on 20th century US urban labor and capitalist development. His work emphasizes the social structures of inequality in modern American society, culture, and politics. He is particularly interested in the interrelationship between two major processes. Number one, former modes of material production on the one hand, and two, what he describes as social reproduction and the governance of the diverse urban population on the other. He is currently working on a second major book project, tentatively titled Our Weary Years: How the Working Class Survived Industrial America. But today, he will talk to us on the basis of the first book, which is entitled The First Shift: The Fall of Manufacturing and the Rise of Healthcare in Rust Belt America. And so without further delay, let us welcome Professor Gabriel Weiner.
Well, thank you, Professor Trotter. Let me just first say thanks to Evie, Jean, for helping to organize and coordinate this event. And I just want to say for a moment, what an honor it is for me to be invited to present to Cause, and to how sorry I am that I can't be there in person with you all. My work is about Pittsburgh, as you know, and in particular, Professor Trotter, your research and your scholarly example were of tremendous importance for me in developing this project. So I'm sorry we've never met. I'm sorry we didn't get the chance to meet today. But I did draw on those oral histories that Cause has conducted over the years, some in doing the research for this project. So I feel both in the tradition, as a follower in the tradition of that you have blazed a trail of, and also kind of directly materially indebted to what you all are doing there. So I'll just get right into it. I'm going to break a little bit with the tradition of history talks and not deliver a completely pre-scripted talk in the hope of being a little more engaging, since I'm coming to you over Zoom here. So I apologize in advance for my ums and ahs. But I will be talking about my book today, and hopefully it will make some contribution to the discussion about reparations and racial justice and economic justice that you all are having there. So I want to start with a genre of journalism, one that I imagine is quite familiar to many of you. This is a genre I started paying attention to as I was researching this project, and we really saw it crop up in the 2015-2016 period as Donald Trump was emerging onto the scene politically. And this is a genre where a national newspaper or magazine sends a reporter to a deindustrialized town. Typically, they find a diner. That's the kind of classic form of it. And they, find some laid off industrial workers to talk to in that diner about why it is that they are enthusiastic about Donald Trump. We've all read a million of these, I think. I pay attention to them for professional reasons, but I often found myself getting quite irritated by these kinds of stories. And in particular, because there was a pattern that I kept noticing in them, which they seem not to notice themselves. Here's an example from the New York Times in 2016, where they've traveled to Indianapolis to cover workers who've been laid off from the famous Carrier plant there. That became a big national issue in 2016. And in the course of this coverage, they talk not just to members of the Steelworkers Union there, but also, as you can see in this highlighted text, to a young woman named Haley Duncan, the 21-year-old granddaughter of the union president, who is about to finish college and take a job in healthcare that pays $14.50 an hour. Here we go with the New York Times to a coal town in West Virginia, where they've gone looking for laid off coal miners, but they found instead a waitress who was the wife of a former coal miner and took an offer to train as a phlebotomist, but in fact, the phlebotomy labor market is flooded, so she wound up working as a waitress. And another woman, Patricia Sigmund, who is now working as a respiratory therapist at a clinic for Black lung disease. Politico, over the course of that election cycle, went repeatedly to Johnstown, Pennsylvania, which is a steel town about an hour and a half east of you all, where their native informant was a retired nurse named Maggie Freer. Finally, here's another example from Monessen, so just up the Mon from where you all are, where the New York Times traveled to learn about steel plant layoffs, steel mill layoffs, and interviewed a guy named Josh Turkovich, who was commuting from Monessen up to Pittsburgh. I think he was working at Montefiore. So this is a kind of interesting pattern, it seemed to me. These healthcare workers are never whom national correspondents are looking for. They're not who they go to find, but they seem to kind of creep their way into these stories as though from the outside. And that's not a coincidence. In each of these towns, Monessen, Indianapolis, Williamson, Johnstown, healthcare, the category called healthcare and social assistance is the largest sector of employment, as in fact it is nationwide now. Nationwide, it's about 1 in 7 jobs. And it turns out, and this will be something I'll talk much more about, in deindustrialized places, it rises to 1 in 6, 1 in 5, at its peak in some places, almost 1 in 4 jobs. That's a quite striking geographical pattern. That's why there are so many of these people who are getting found, even though no one is looking for them in these stories. Now, we all now know quite well that the United States has undergone a dramatic long-term process of deindustrialization. This is a graph for you of the percentage of manufacturing employees as compared to all employees since 1950. And we can see it declining pretty linearly. I mean, there's little ups and downs, but pretty linearly from its peak in 1950, that's around the time of the Korean War, down toward the present. But this process of deindustrialization has been, I think, very disorienting on quite a number of levels, because for those of us who are concerned about social, racial, economic inequality, we have a tradition of understanding mechanisms of class formation, proletarianization in Professor Trotter's formulation, and social and political conflict that understood class as an important category of those conflicts, but one that was very, very deeply rooted and connected to the industrial economy. And so a problem arises when you don't really have that much industrial employment anymore. Can we still use these same terms of analysis? Can we still understand society in some of these same ways? What was the baby here and what was the bathwater, right? When we lose the factory, what else do we lose with it in terms of our ability to understand how society works? And also to imagine groups of people who might have the capacity to engage in social and political struggles for a more democratic and just and equal society, a role which has often, although not exclusively, been assigned to industrial workers. But if we're talking about the end of the forward march of labor, farewell to the working class, the last days of the working class, we then have to ask, are we now in a society that doesn't have such a thing anymore? How could that be? What would that mean? Indeed, over the course of the final decades of the 20th century, it became increasingly common to say that not only was the industrial working class gone, but class itself no longer existed in a meaningful way. In American society, more broadly in wealthy post-industrial societies, with the decline of both socialist and social democratic political parties across many societies, the decline of trade unions across many societies, and the fall of state socialism. This basic organizing principle seems suddenly to become quite obviated. And this, I think, is in some ways a familiar story, not just at the global level, but at the urban level as well. For you all in Pittsburgh, I'm sure you've heard many versions of this. I grew up in Philadelphia. I did my PhD, as Professor Trotter said, at Yale, which is in New Haven, also a former industrial city. And across all these cities, there's a very now kind of shop-worn, familiar Renaissance story that gets told. Yes, over the 60s, 70s, and 80s, things got bad, jobs were lost, people moved out, population shrank, the city decayed. But then in the 1990s and 2000s, young people began to move back. They were attracted to, they were sort of high-skill young professionals who were attracted to work in what were often called anchor institutions, such as universities and hospitals. And that process initialized a urban renaissance dynamic in which former factories could get made over into lofts, new kind of clean, high-skill industries could grow. Again, I think this is a very familiar story to all of you in Pittsburgh. And I don't think it's wrong, exactly. I remember being in New Haven myself, thinking about this and thinking, well, that story describes me at some level. Here I am in this post-industrial city to do a PhD. But I could also look around and see that there were a lot of people there in New Haven, as there were in Philly, where I grew up, and as there are in Pittsburgh, who are also connected to these same institutions, but not in the same ways that I was as a graduate student. They're connected as custodial workers or clerical workers or food service workers or as nursing assistants in the hospital, or they were perhaps in medical debt to the hospital, or they were perhaps being policed by the university police, or they were perhaps being pushed out of their neighborhood by university-driven real estate development projects. And so while I don't think that the story of a kind of urban renaissance was totally inaccurate, it seemed very partial. And that partiality, it seemed to me, was presented a kind of intellectual opportunity as well as a kind of political problem. Because if we could figure out who else is tied up in this process, who else is part of this, besides me, the kind of stereotypical young professional creative who's moved back to the city, who else am I in the mix with, then it might be possible to tell a story not about the end of the working class, but about the recomposition of the working class. That we have an idea when we say, perhaps, for many, when we say the phrase working class, we evoke a probably white, probably male factory worker in the 1950s and 1960s. And that idea, that image became very conflated with a more abstract concept. But the abstract, you can lose the example and keep the concept, and maybe the concept gets new examples. And in fact, I think over time, over the course of the history of the development of capitalism over centuries, that process has actually happened many, many times. The reality that capital has to employ labor doesn't necessarily tell you that much about who labor is, who winds up in that role, and what it means for them that they're in that role. And that the answers to that question are going to change and change and change again and again. So in trying to answer that question, I started thinking about, well, what are the low-wage jobs in this new post-industrial economy? Who are these other people who work at some of these same institutions that I might? We know that wages in this country have been stagnant or declining since the 1970s, so surely not everyone is a high-skilled, high-paid young professional. And it emerges that something called the care economy accounts for a tremendous portion of low-wage job growth over the past several decades. So defining the care economy broadly as employment in healthcare provision, childcare, elder care, some forms of food service and hospitality, and domestic work. The care economy has accounted for 56% of all new low-wage jobs in the 1980s, 63% in the 1990s, and 72% in the 2000s. It's a tremendous portion of low-wage job creation. Whatever new forms of social inequality are emerging, it seemed to me this is where to look for them. This process is also gendered in an important way. It corresponds, although the details of how are important to get right, it corresponds in time in some way to the massive expansion of women's labor force participation, right? We can see, I just told you these numbers for the 1980s, 1990s, and 2000s, and we can see how pretty closely that corresponds to the entry of women into the workforce. The care economy workforce is a workforce disproportionately of women. It's also geographically uneven, as I began to allude to earlier. So if you look at urbanized counties in the United States by the proportion of their workforce, which is in healthcare and social assistance, and then you take the top 25, here is the list that you get. I don't know if you all can read it in the back there, so I'll read it off to you from top to bottom. I'm going to read you the largest city in the county rather than the county name, because you might not know all the county names. The Bronx, Philadelphia, New Haven, Cleveland, Brooklyn, Pittsburgh, Boston, Newark, Rochester, Worcester, Lynn, Hartford, Quincy, St. Louis, Queens, Milwaukee, Yonkers, Buffalo, Hempstead, that's Long Island, Baltimore, Detroit, St. Petersburg, Florida, Portland, Oregon, Cincinnati, McAllen, Texas. So up until maybe Long Island or maybe St. Petersburg, Florida, these are all the same kind of place at some level, right? These are all deindustrialized places. And that's a pretty striking geographical pattern. You might expect to see on here Phoenix, Arizona, which is a concentration of retirees, right? Or maybe Broward County in Florida, but they don't, St. Petersburg does appear here. We have one Florida example, but this is actually quite a different map than you might have guessed that you would find for this variable. In fact, there's a whole set of kind of historical resonances and connections between the industrial economy and the healthcare economy. So if anyone's from the West Coast, you're very familiar with, I'm sorry for this grainy image here, you're very familiar with the hospital chain, Kaiser Permanente, which is all up and down the West Coast and has a couple of outposts on the East Coast as well around Washington, D.C. Kaiser Permanente has its origins as the healthcare plan for Kaiser Industries, which was a construction, steel, and shipbuilding corporation, which developed a health plan for its employees in the 1940s. Gradually over time, the health plan became the company. Another example, this is Pennsylvania here. Up and down Appalachia, there used to be hospitals with names like this, Miners Medical Center. There are not very many left now. But this is a kind of a leftover residue of that same pattern I was talking about a moment ago, where there used to be concentrations of industrial workers. There are now, as a kind of after image, these healthcare institutions and these large healthcare workforces. So I focused in on Pittsburgh to study this, and the reasons why I probably don't need to elaborate for this audience too much. But it seemed to me that Pittsburgh has long been the kind of place where people can go to study the transformations of capitalist society and work in capitalism and the forms of social and racial inequality that attend those transformations. People have been doing that in Pittsburgh for over 100 years, and that generated a lot of material I thought I'd be able to draw on, and Pittsburgh could kind of stand in for me as a way of understanding this larger dynamic for reasons that are plain if you look right at the skyline. Here you see the Pittsburgh area relationship between employment in the metal industries, which is the dashed line, and employment in healthcare and social assistance, that same variable I was describing a moment ago on a wider scale. And you see the relationship, they seem to be quite closely mirrored. In particular, they cross each other in 1980. So this then raised the question for me. What is the connection between these two processes? The loss of employment in the steel mills, the rise of employment in hospitals and nursing homes, and eventually home care. Are these just two episodes, or is there some relationship between them? That you can think about on TV shows how it used to be, a sitcom, it used to be that each episode had a separate story, but now a lot of TV shows have a story that kind of goes all the way through the season, and what happened in each episode has to do with what happened in the episode before. And I wanted to understand if something like that was going on here, if there was, in this kind of after image dynamic that I was describing to you a moment ago, if there was something that the rise and fall of steel had to do with the rise of the healthcare industry. So that's what I'm going to be talking about for the rest of the talk today. But I want to start pretty near the present in an episode that some of you may know about or remember in 2013, when the University of Pittsburgh Medical Center, in part of its ongoing, seemingly endless labor dispute, claimed before the National Labor Relations Board that it has no employees. As you can see in this quotation, UPMC is a holding company which holds certain ownership interest in other entities. UPMC has such directors and officers as are legally required, but has no employees. Now, this was a claim about parent company versus subsidiary. They were saying the UPMC is the parent company and the union has to take up its business separately with each hospital. But it turns out that Pittsburgh hospitals have been saying that they have no employees for quite a long time. So here is a newspaper story from 1940, and I'll point your attention to this article on the left here. Shortly after the steelworkers had successfully organized their union in the late 1930s at U.S. Steel, that energy began to spill over into neighboring industries, and a group of African-American nurses began to try to organize a union at West Penn Hospital. And in response to this, the 26 hospitals of the region together brought a lawsuit to essentially get an injunction against picketing and the unionization effort. And their argument was that they are not employers. Now, the particular legal logic of this argument was not identical. It was not the same as the argument made by UPMC in 2013. The particular argument in this case was that these are nonprofit philanthropic institutions. They're not engaged in commerce, so they don't fall under the regulation of labor law. But I think we can set aside those differences in some ways and say that there is an interesting continuous pattern. It changes in some of its legal details, but there is a continuous pattern from 1940, from this moment, up to 2013, within which these kinds of institutions make these kinds of arguments, that they are not part of the ordinary economy. They stand outside of it in some way. They don't follow the same rules. They don't serve the same functions. And that position on the kind of outside of the economy, it's rhetorical, right? It's invoked for legal purposes, for whatever instrumental reason, a hospital trying to win a lawsuit, this kind of thing. But it also describes something real about the structural position of healthcare in 20th century America, and the way that our healthcare system was designed in relation to our industrial economy. But to tell this story, I think we need to go back to the 1940s and 1950s, and some of the kind of dynamics of social and political conflict of those years, which we often think of as a kind of, or many think of anyway, as a kind of a golden age of relatively high social equality and social solidarity, when trade unions were stronger, when the welfare state was stronger. And that's not, again, not an altogether untrue story, but the thing that I'd like to ask you all to think about with me is the unevenness and uneven and contradictory and paradoxical qualities of that strength. The strength of organized industrial workers was not the strength of all working class people. And in fact, they were divided against each other in various ways that are important to pay attention to understand what came next. So let's begin this story in 1947. After the Republicans took back Congress in the 1946 election, on the heels of a major strike wave across virtually all of American industry, the Congress passed the Taft-Hartley Act, which severely restrained workers' bargaining power in various ways. We don't need to get into the details all here. One thing that the Taft-Hartley Act did was resolve the question that those hospitals had been suing over in 1940. The question of whether hospitals were covered or not by the National Labor Relations Act was ambiguous in 1940. That's why they had to have the lawsuit. In 1947, it stopped being ambiguous. The Taft-Hartley Act legislated that hospitals are not engaged in interstate commerce. They are not subject to labor law regulation. They were also not subject, incidentally, to the Fair Labor Standards Act, which sets minimum wage, maximum hours, and so on. And so whatever was sort of ambiguous through the years of the 1930s and much of the 1940s, in 1947 was resolved for several decades. Hospitals were structurally, legally, institutionally positioned outside of the regulated sphere of the economy. Now, this happened at more or less the same moment in time when the effort to expand the welfare state in the arena of healthcare ran into a major roadblocks. So Harry Truman, coming off, succeeding Franklin Roosevelt, wanted to take up the agenda that Roosevelt had in some moments attempted to pursue of a national health insurance plan, what we would maybe now call today Medicare for all. This is something Roosevelt had kind of gestured at various times without ever totally pursuing, and Truman wanted to make it his kind of flagship domestic policy effort. So he put forward a bill to establish a national health insurance program. But this was in the moment where the Cold War was beginning, and socializing a significant area of activity seemed increasingly politically toxic. And in particular, for the industrial unions, the steel workers, the auto workers, the mine workers, the electrical workers, the dynamic new industrial union movement that had formed in the 1930s and gotten stronger in the 1940s, then had hit this roadblock of the Taft-Hartley Act in 1947. This was a challenging moment because they were the main base. They were the main constituency advocating to continue building and expanding the welfare state. but they had gotten knocked back on their heels by the beginning of the Cold War. They had many communists who'd been involved in organizing them. They were seen as sort of tainted with the stain of communism. And they were trying to improve their image against that backlash. And so they withdrew from the fight for a national health insurance plan, although they had been its major constituency up until this point. They sort of left Harry Truman hanging. And, figuring that they no longer had the political power anymore in a Cold War environment to compel the federal government to adopt new policies like that, they instead turned their attentions to private sector welfare benefits and sought to negotiate health plans through the collective bargaining process. So in steel and in autos and in coal and in electrical and in many other similar industries, meat packing, we could go down a long list. Over the course of the late 1940s and early 1950s, industrial unions began to negotiate the first widespread sort of systematic private sector health insurance plans through their collective bargaining processes. There were examples before this of people getting health insurance through their jobs, but this is really the moment that it becomes the norm. In 1949, the federal courts ruled that health insurance and pensions are what are called mandatory subjects of collective bargaining. So if you are a member of a recognized union, then your employer is obligated legally to negotiate with you over the subject of health insurance. And prior to this moment, working class people in this country very rarely had something that we would recognize as health insurance. This is the moment when it spreads across the working class over the course of the 40s and 50s through private sector collective bargaining after the failure of the political effort to win it through the public sector. Now, at the same time, the steel industry is, to focus it on Pittsburgh a little more, the steel industry is not necessarily running quite as smoothly as some idea we might have of it as, like I said, a post-war golden age. You can see there are quite frequent recessions in 1948, 49, 53, 54, 57, 58, 60, 61. And this is not to mention the strikes that are happening, but with about the same frequency through this period of time. Steelworkers are quite often out of work for one reason or another, on temporary layoff for a couple of months, on strike for a couple of months. Here's a list of every year in which either a recession or a strike was in effect over the course of the 40s, 50s, and early 60s. Including in 1959, when steelworkers engaged in the largest strike in US history in terms of person hours idled, when about 500,000 workers went on strike for about 4 months. Now, this matters for the story that we're telling here because it had real implications for their standard of living, and their standard of living would have real implications for the way that they related to their healthcare benefits and the way they use those benefits, which I'll get to in a moment. But before we get to that, I just want to say a word about standard of living of industrial workers and how important it was, not just materially, but really at a kind of ideological and political level, how much the question of how well are our industrial workers doing mattered in people's imagination of how the country was doing and how the Cold War was going. So some of you probably know this famous scene of Richard Nixon when he's vice president in Moscow. This is the so-called kitchen debate, where he's traveled to Moscow for a kind of exposition of American society and American goods. And he's taking Khrushchev, the Soviet premier, on a tour of a model American home. So they enter the kitchen, and Nixon, I'll read you the dialogue. Nixon says, "I want to show you this kitchen. It is like those of our houses in California." Khrushchev says, "We have such things." Nixon says, "This is our newest model. This is the kind which is built in thousands of units for direct installations in houses. In America, we like to make life easier for women." Khrushchev says, "Your capitalistic attitude toward women does not occur under communism." Khrushchev is much funnier than Nixon, it turns out. Nixon says, "I think that this attitude toward women is universal. What we want to do is make life more easy for our housewives. This house can be bought," Nixon says, "for $14,000. And most American veterans from the war can buy a home in the bracket of $10,000 to $15,000. Let me give you an example that you can appreciate. Our steelworkers, as you know, are now on strike. But any steelworker could buy this house. They earn $3 an hour. This house costs about $100 a month to buy on a contract running 25 to 30 years. So there's a kind of idea of the tremendous importance of the standard of living of American industrial workers, not just for themselves and their own well-being, but for the country and the country's larger ideological battle in the Cold War. The idea that American society had solved the labor question, had answered the class question in the form of the well-being of industrial workers. Again, this largely white, largely male group was critical to actually winning the Cold War. But I want to also just take a note to remind you, or point you back toward the fact that what Nixon emphasizes is the well-being of the worker's wife and family. In the Cold War, in the post-war years, the way that economic security was extended across the working class, this is implicit in what I've already said, but let me develop it for you, was through the relationships of the household. So you had the industrial worker who was able to get a job, hopefully, ideally, at a place like US Steel. And then you had his wife who got access to the economic security that he enjoyed through his collectively bargained private sector benefits only through marriage. She has no other way to access that. And then their children who similarly access it through their relationship to their father. And so it's through the family that the kind of economic security that the labor movement has won is being routed and dispersed out to the population. And the family becomes the center of, to repeat the phrase Professor Trotter used in his introduction of me, social reproduction. That's to say the activities that get labor again ready for the next day at work. Keep the body fed, keep the clothes washed, keep people happy and clean and warm and able to function as workers and produce the next generation for the same purpose. The family goes with the factory, and it's in the post-war years that working class people who are able to get industrial work, which is a racialized question I'll talk more about in a moment, come to organize more and more into a kind of nuclear family model. However, the rosy picture Nixon paints is not quite right, it turns out. He said our workers make $3 an hour. And it's true that steel workers, if you annualize their hourly wage on average in this moment, made $3.36 an hour. That's to say, if you figured, okay, they make their average hourly wage was $3.36. And if you annualize that, it comes out to $6,720 a year. I had that backwards. And that would appear to put them well above the standard that Nixon was talking about, or the Bureau of Labor Statistics standard, which is described here for a modest but, quote, modest but adequate standard of living. Now, let's note this is not suburban comfort exactly, right? The standard of living involves a rented dwelling, not an owned home. Involves just a few items of clothes for just 2 children every year. These families were often quite a lot larger than that. We have maybe an idea of post-war working class people as enjoying home ownership in suburbs and this kind of thing, but that's actually not quite what it was like. But even this standard, they fall short of, because although their annualized hourly wage would lead you to think that they get $6,720 a year, in fact, they're on strike, they're on strike or in recession frequently enough that they fall below this. They fall below an average of $6,000 a year. And so they're economically, even the kind of most privileged and secure, largely white strata of the industrial working class are economically less stable than the general image that we have of them. Similarly, we have an idea, which I was alluding to a moment ago, of this moment of a single earner family as the kind of dominant model, because the men enjoyed such economic security. And it's true, if you look at this chart, that married women in Pittsburgh worked for wages separately from their husband at rates quite a lot lower than married women nationally did. There's some racial differentiation, but the pattern holds across racial lines, that married women in the Pittsburgh region sought employment less. But that's maybe not such a simple story about how comfortable and good they had it because their husbands were doing so well. Remember, their husbands were actually not really able to deliver on this standard of living. They were not really able to deliver on Nixon's promise. In fact, working class women have to stay in the home and do a tremendous amount of work to hold things together through all the disruption of strikes, layoffs, injury, sickness, all of the challenges of social reproduction of their households for the next day at work, for the next generation. There's a tremendous toll that it takes on a family, on a population, on their bodies and on their spirits to sustain steel production in the way that was going on or industrial production in general in the way that was going on in mid-20th century America. And it involves quite a lot of unwaged, unrecognized work for women. That work takes all kinds of forms. Because it's not waged, because it's not formalized, it's difficult to kind of isolate it. And it looks seamlessly part of the life of the family. But as many said, cooking and cleaning was all I ever did. We were in and out of the kitchen. These are various quotations from different working class women. We were in and out of the kitchen all day long. I used to sleep most of the day because I'd stay up all night washing the kids' clothes. I always cooked a meal when he came in. And this is an important element of this. Steel mills ran 24 hours a day. They were broken up into 3 shifts, which were typically 8 to 4, 4 to 12, 12 to 8, or something like that. That meant that a third of the workforce at any given time was working the normal, more or less normal working day. But the other 2 shifts ended at midnight and at 8 in the morning. And that meant that wives of workers might have to cook 2 dinners, right? One for their children, one for their husband. They might have to do laundry in the middle of the night because that, for example, here, that would be the only time that they had to themselves potentially to do it. Washed clothes all day today, as this diary entry says. Ted went out for 4 to 12 for his first 4 to 12 shift in a long time. I sorted clothes and ironed until 20 after 1. Then we both went to bed at about 1:30. Pretty tired tonight. There's also an important element of cleaning that we should not overlook. The Mon Valley was tremendously dirty with the emissions of the steel mills. And housewives knew which whistles and sirens and bells meant which kinds of things were about to come out of the smokestacks, and would tell them, do I have to run back and, as this quote says, grab our clothes off the line? We see big clouds of smoke coming from the mills. Their windows, their stoops of their houses, their cars were covered constantly in soot and dust and ash and cinders of different kinds, not to mention the bodies of their husbands and the clothes of their husbands when they came back to work. Would often have forms of grime and soot and ash under their fingernails, above their eyelids, in the kind of seams of their clothing. And then you'd have to decide, am I going to scrub it down with lard to try to get that out? Am I going to wash it in the washing machine, but the dirt will silt up in the washing machine and degrade it more rapidly? So all of this, women are having to figure out day in, day out, to keep that labor supply of their husbands going for the steel mill for tomorrow. And then there is the care of the body itself, of young people, right, who have to be fed and attended to, of husbands who have to be also fed and attended to, particularly often after a very long and hard day at work, and of the many elderly, disabled, or sick people in a working class community. And this is an important part of the kind of informal labor that women are expected to do. And let me remind you again, this is not really an option. There's no optionality here, really, because marriage is more or less mandatory. There's no other way to get access to economic security except through marriage. And then marriage has essentially a job description, which involves, as one woman says here, I took care of him because I had no other ways, no one to come and take care of him. This is after her husband is injured, because he didn't want nobody, excuse me, after her father was injured. He didn't want nobody but me to take care of him. Or as another says of her grandmother, I think, I would help bathe her. She was bedridden. I would make sure she had something to eat. And another, I neglect myself. I take care of everyone else in the family that's sick. I enjoy it, really. So, of course, people feel all kinds of ways about this. They enjoy it. They resent it. Many things in between. But they have to do it. And I think that's the important part to understand. Then there's a kind of area of social reproduction, which we've already been talking about, which extends beyond the home itself. And this is the kind of institutionalized form of social reproduction. The school would be an example of this. Later, nursing homes will be examples of this. But in the middle 20th century, hospitals become a really important example of the kind of larger sphere of social reproduction that mimics, in some ways, the kind of patterns of the family, but is different from them in important ways. And hospitals begin to expand very rapidly over the course of the 1950s and 1960s, and then even faster in the 70s and 80s. And I'll talk more about this, as you have these large pools of insured people for the first time. The working class has insurance. And so hospitals begin to build new wings. You see here the opening ceremony for a new wing at Homestead Hospital, which no longer exists, but it was a few blocks up from what's now the mall in Homestead. This is because steelworkers have this good pension plan and social insurance, and through it, they anchor a large healthcare market in the region. And so hospitals understand that if they expand, there will be a market for their services. And just so you can kind of see it in a more quantitative way, here's a comparison of what's called healthcare utilization. It's a horrible phrase that they use in health economics. How intensively people use the healthcare system, the hospital system, steel subscribers, that's to say steel workers and their families, compared to the general population under 65 in the late 1950s. And you can see steel subscribers are using their health insurance at rates quite a bit higher than the general population. So now let me return to the question of deindustrialization. I've described this whole system of social reproduction to you. And to sum it up, you have the steel worker through whom benefits and economic security are routed through his job, collective bargaining at his job, but he in turn depends on the family that they get access to his benefits and his economic security, his wages. In return, he depends on his wife to keep him going in the variety of ways I just described. And as he ages, on his daughters probably to take care of him, or his daughters-in-law. And then beyond that, if he gets very sick, right, or his family does, they'll have the hospital that they can go to on that high quality private sector collectively bargained insurance that they have. But the hospital is not a part of that same system of social protection and regulation. The people who work at the hospital, and we'll talk more about this in a moment, they're not unionized. They're not protected by those rules. Their families don't have that same kind of protection that his family has. So this whole system is built around the industrial worker. It's designed to keep him going, to keep the steel industry going. But then what happens when you remove that centerpiece, when you start to get layoffs at steel mills? Here again is this graph, and you can see this process of decline in employment in steel is long, right? There's a long, long grinding away of economic security, and then a quite rapid decline in the 1980s. Well, this process, first of all, is racialized. So Black workers were able to get jobs in the steel industry from the early 20th century, but they were excluded from unions until the late 1930s. And even when they were integrated into unions and the United Steelworkers had a kind of civil rights policy of some kind, and official non-discrimination was in effect, there was lots of de facto discrimination in the steel industry. This is a very now well-told story by many historians before me. Typically, African-American workers would be the last to be hired, the first to be laid off in a recession, and they were confined to the worst jobs in the steel mill, both the ones that were most likely to be laid off and also the ones that were most damaging to the body. What that meant was that kind of image that Richard Nixon painted that I described for you of the post-war dream for the industrial working class, toehold really of that were available to some number of working class African-American families, but not very many and not for very long. And already by the 1960s, Black workers were being pushed pretty systematically out of the steel industry, something that would only happen for white workers over the next couple of decades. And this meant that they had to secure their means of social reproduction in a different kind of way, right? They couldn't rely on that same system that I just described, or not many of them could anyway, for very long, on that same system that I just described. They had to instead seek out other strategies for economic survival and well-being. One of these was the welfare rights movement, which emerged across urban America in the late 1960s and rural America in some places in the late 1960s, and consisted of social movements typically led by African-American women, poor women, demanding higher quality welfare benefits, more generous welfare benefits, and less degrading conditionalities around collecting those benefits, which was often a very invasive and humiliating process. And Pittsburgh had a very vibrant welfare rights movement that was founded and led by a woman who you see here named Frankie Mae Jeter. who was a hospital worker herself, actually worked in the laundry at Presby, I think. At hospitals, which became the largest sites of African-American women's employment over the course of the 1960s, replacing domestic work as the main form of Black women's employment. Workers also began to organize themselves. Although they were not legally protected by labor law, nonetheless, they fought for union recognition. And you can see their critique in this pamphlet from this campaign, their critique of the legal position that they were put in, describing their employment at Presby as dictatorship and as a plantation. Now, that's, you can think of that as mere rhetoric, but I think we should take that seriously when they say we don't have the rights that free workers in this country are supposed to have. And indeed, it was true in this organizing drive, which the hospitals managed to defeat in 1969, 1970. They defeated it by use of a whole variety of tactics, which in a steel mill would have been illegal. Retaliation, intimidation, different kinds, inviting in rival unions to compete with each other, and so forth. So African-American workers are trying to figure out how to navigate the beginnings of deindustrialization, but deindustrialization is going to gradually expand to affect more people. And it's going to change the conditions of work in the healthcare industry. So let me talk for a few minutes about the kind of structural conditions of that process. One key element of that process is it causes the population to age. So here you see the Pittsburgh area versus the United States and the percentage of its population over 65 from 1970 to 1990. And you can see quite dramatic expanding gap between the region and the country as a whole, from a small gap in 1970 to a gap of 50% in 1990. By 1990, Pittsburgh was the second oldest urban county in the United States after Broward County in Florida. Sorry, let me say one word about why that is also. So as this quotation suggests, people out-migrated, especially young men tended to out-migrate because as steel jobs were diminishing, there were few opportunities for them to get onto the seniority ladder. And meanwhile, that large steel worker cohort that was in place around 1950 in the Korean War was never fully replaced and sort of aged in place. Now, an aging population is also going to be, in various ways, a sicker population, in both direct ways and other forms I'll talk about in a second. But as this population ages in place, but enjoys this very good quality health insurance, they begin to use the healthcare system even more intensively. So I showed you earlier the gap between steel subscribers and the general population. In these numbers, you see the gap between steel subscribers and other Blue Cross subscribers. So that's a higher bar than the general population. That's other insured people. And by the end of the 1970s, hospital utilization in Pittsburgh region has reached 1.6 inpatient days per capita, which, to break that down, means that if everyone in the region used the hospital the exact same amount, if everyone went to the same degree, everyone would have spent 1.6 days in the hospital in 1979. Now, of course, that's not what happened. What happened is most people don't go at all, but a lot of people go, and they go for a long time. So it averages out to 1.6 days per person. That's triple the national rate. We now have a rate of about 0.55 in the present, I mean. So as that's happening, right, you have this aging, well-insured population using the healthcare system very intensively. The healthcare system has to hire people. Who is it going to hire? It's going to hire people who've been pushed out of the position of the kind of housewife who Nixon describes. And as you see in this quotation, the displaced homemaker is tailor-made for the homemaker home health aide position and could be said to have been in training for the position for many years. Those expectations of women become a form of job training. And of course, this was true first for African-American women who get pushed out or denied access to that kind of economic security first and most intensively. So all of that is kind of gradually grinding away over the course of the 1960s and 1970s. And then in the early 1980s, it accelerates very rapidly as unemployment speeds up, getting as high as 17% in 1983, reaching 25% for African Americans. The poverty rate doubled between 1976 and 1983, and this overwhelms the welfare systems and social assistance systems that exist. Whatever kind of savings people have are wiped out as they try to, older generations try to sustain younger generations. Immediate risk of death for unemployed, laid off workers skyrockets actually through a whole set of sort of socio-medical mechanisms like mental health, addiction, heart disease, domestic violence increases, suicide increases, there's a general catastrophe. But as this happens, the healthcare systems that were set up in this earlier moment actually proves to be the only thing that's really able to withstand it and to respond to it. So you have the retiree benefits of this growing number of elderly retired steelworkers. You have Medicare supplementing that. You also have Medicaid, which is a counter-cyclical program. So if you lose your job, your income falls, you might qualify for Medicaid. So Medicaid actually expands even as much of the welfare system is getting kind of crushed. Here you see the proportion of US Steel employees who are active employees versus pensioners. And you can see a very rapid increase in the number who are pensioners between 1978 and 1984. That's people taking early retirement packages rather than getting laid off, because if they do that, they get to keep their benefits, their retirement benefits. And this dynamic, this kind of complex, aging, getting sicker, getting poorer combination, drives people to use the healthcare system even more. Because what it does is it denies them access to first of all, it gives them health problems directly, but it also denies them access to the unwaged labor of the women in their families who are now having to seek jobs because their husbands don't have jobs anymore. But to compensate for that lost access to unwaged women's labor, they can use their health insurance to go to the hospital and use the hospital kind of like a social work agency, kind of like a nursing home. The result of this is length of stays in hospitals rise across the Rust Belt. Again, here are the top 24 cities in 1981 by average length of hospital stay. I believe the only city on this list that is an outlier is Washington, D.C. Every single other city on here is undergoing deindustrialization in this moment. And as that demand for the healthcare, for the hospital system grows, even as everything else is collapsing, it means that investment flows into the healthcare system, even as it's flowing out of everything else. So here you can see from 1979 to 1980, more than tripling, approximate tripling of capital investment in Pittsburgh hospitals, which then rises further in 1980-81. And this speeds up employment growth in this industry. Again, in a moment when employment is collapsing all across the rest of the economy in the region, you have this very steady expansion in healthcare employment growth. But this is not equal growth. And this is to return to, and to begin to wrap up this talk, to return to the point where I began. If you have an image of the healthcare system and the people who work in it, you might think of doctors, you might think of even registered nurses, who are kind of ambiguous category. Are they working class? Are they middle class? Are they professionals? But even below registered nurses, you can see that 2/3 of the healthcare workforce in 1992 is paraprofessional and lower ranking in the occupational hierarchy, earning quite low wages. That is a process that solidifies a kind of gendered and racialized labor market inequality. Let me go back, actually. So African Americans in Pittsburgh are concentrated in these bottom two categories and have a quite hard time rising up above or accessing jobs up above them. And similarly, women are concentrated in the categories from registered nurse down and are rarely able to get into the higher wage jobs in the healthcare industry. Healthcare remains today more than 3/4 women. This is part of a larger structural transformation of the economy. You can see here, these are the average price changes by different sectors of goods, with hospital services, various college-related things, childcare, medical care, rising really fast in their general cost as compared to manufactured goods. That's because the healthcare industry is not really able to achieve what economists call productivity increases in any kind of steady way. If you can't really replace labor with capital, with machines that easily, you can't really provide the service more efficiently without degrading its quality. And this means that prices rise even though wages stagnate. That's the opposite of how things are supposed to work in capitalism, right? The normal pattern is what you see for these manufactured gadgets, where they get cheaper over time, but the people who make them get paid more, because as they get cheaper, more people can buy TVs, and the TV maker makes more money and pays its workers more. That's supposed to be the normal pattern. Healthcare runs the other way. But healthcare and industries like it have taken up more and more of our employment over time, in this kind of structural transformation of a shift toward labor in these low productivity industries. And this has important consequences for what it's like to work in these industries. And this is the point I want to use to kind of bring to a conclusion. If you have this industry for which its demand is driven by social inequality, which is what I've been arguing to you today, that as we get deindustrialization and a more unequal society, the healthcare system becomes one of the very few institutions able to respond to and partially manage that inequality. We dump that inequality, we shunt it into the healthcare system to take care of it for us. But then the healthcare system is not really able to get more efficient as it manages those inequalities. It just has to force the people who it employs to do their best. And that generates a systematic experience, not just of wage stagnation, but also of extreme stress, which we've seen very, very clearly in the pandemic. These are all quotations of the 1970s and 1980s as the industry was taking off. But I think you could easily find any number of healthcare employees who would say similar things now. The industry that stands out as very stressful is the healthcare industry, as one survey puts it, as one LPN puts it. I had 2 miscarriages. I get migraine headaches if I get overly tired. At the end of the 7-day stretch, I have a tension headache like you wouldn't believe. I come home and my 2 days off, I'm sick. Then I go back to work. And this leads us, I think, to a general paradox that's worth paying some attention to. And is the point I want to leave you with. This is the paradox of the essential worker, right? I think we've all seen over the last few years the strange way that we've described work in the healthcare industry as having these kind of essential qualities. We've recognized how important it is to holding our society together. And in fact, as I've been arguing to you today, that it's had that quality for quite a long time. We've asked it to serve that function since the 70s and 60s, if not earlier, and especially since the 80s. But we've also positioned it in this way where we're structurally, we seem not to be able to acknowledge our dependence on it. And that's because of the kinds of people who are relegated to work in this industry, right? We require all of these needs, we require it to service all of these needs of our society, which is why we spend more and more and more money on it and why it grows and grows and grows. But then we dump the burden of actually carrying out these functions on largely the poor women who have few other options in the labor market. And in Pittsburgh, that tends to mean disproportionately African-American women. In other places, that tends to mean immigrants. So these workers collectively are essential, and we can't acknowledge it enough. But individually, they're disposable. And I think, while that's a very depressing story, it also generates political possibility, because our collective dependence on these workers, while treating them individually as though they're disposable, also creates the opportunity for them to, and I think they have increasingly begun to do this, critique the situation they're in collectively and organize around it, either in political forms by running for office, as we've seen growing numbers of nurses do. Here is India Walton, a former nurse who won the Democratic primary for mayor in Buffalo. The Congresswoman Cori Bush from St. Louis is a nurse. On the right here is Farrah Forrest, who is a nurse who serves in the state assembly in New York, and also in industrial action of different kinds. And I think that is a kind of a sign of a class formation or proletarianization process happening that's not identical to the one that happened in the industrial economy, but has different dynamics. The industries work differently, and the participants themselves are positioned differently, in particular by race and by gender. But my hope is that it will continue and accelerate and become a major force for a more equal society going forward. I'll stop there. I'm sorry, I went a little longer than I wanted, but I'd be happy to discuss this and take any questions. Thank you for listening.
Thank you very much.
I can't really see in the room, so I'm going to count on you all to call on people for me, I guess.
Okay, and Isabel raised his hand. You want to go ahead?
Yeah, thank you so much for that wonderful presentation. I'm excited to go through your book on working on the history of racial segregation in American healthcare based in St. Louis. So in many ways, you offer kind of a way for me to read. It helps me to explain what I also see happening in St. Louis, this transition. As an historian of medicine, I'm really interested in sort of professionals, and you spent a lot of time talking about industrial workers and healthcare workers. And you mentioned very briefly the nurses and the physicians, but it seems that there might be some sort of process of proletarianization happening with them now. I've actually talked with Joe about this very briefly. Could you kind of maybe describe for us a little bit sort of how medical professionals fit into this story? I'm also thinking about Black medical professionals, not just as sort of low-paid health workers, but Black doctors who are also trying to get access to hospital. And Dr. George Simpkins himself, who successfully sues Albert Richardson Hospital in North Carolina, so that he could and his patients can get access and that he can practice in that hospital. So if you could just talk a little bit about kind of where professionals kind of fit into this.
Absolutely. It's a great question. It's a very complicated question, as you're alluding to. Let me say there's a couple different pieces. So first, I think lots of that struggle for access for both Black doctors and Black patients has happened in Pittsburgh, in particular in the Homewood neighborhood. Professor Trotter himself has written about this. The Homewood, for a long time, there was only really one hospital in the neighborhood, which was called Pittsburgh Hospital. It doesn't exist anymore. And virtually none of the admitting, I think maybe one or none of the admitting doctors, I can't remember it exactly now, had offices in the neighborhood or were Black. And so there was a kind of big political struggle in the late 60s and into the 70s over basically forcing Pittsburgh Hospital to operate a community clinic using war on poverty funding. And similarly, the Hill doesn't have a hospital. And some of you may know the story that, in fact, the first EMTs in the country were in Pittsburgh in the late 60s. I'm seeing nodding in the room. And, because previously the way that you got, if you had an emergent need, the way you got to one of the hospitals was by calling the police. And that was for various obvious reasons, not satisfactory. And so, again, war on poverty funding was used to develop an ambulance service and the first EMTs. It's also worth saying that, a lot of the Steeltown, I didn't talk enough about this, but a lot of the Steeltown community hospitals, Homestead Hospital, McKeesport Hospital, Aliquippa Hospital, and the Steeltowns, they had some kind of complex pattern of racial segregation and integration kind of going on simultaneously. But those were hospitals that were, for the entirety of the post-war period, very tightly interwoven with the community needs. And that's not to say they were not racist and discriminatory in various ways, but, people could access them if they had that insurance. And so one of the kind of losses of the loss of industrial work also meant, as that happened in a kind of racially uneven way, also meant often that loss of access to these community hospitals where there were significant Black communities all up and down the Mon Valley. But to talk more about professionals, first of all, maybe Adia Wingfield's book, which I really recommend. So she is actually at Wash U in St. Louis. She's a sociologist, and she's written about Black nurses and doctors. It's a sociology of Black professionals in medicine, and it's an excellent book. But, it seems to me that I think, especially for nurses, there's a very complex kind of process going on where nurses are often, like registered nurses with a degree, are often the highest earner in their kind of extended family. And, well, if you just see their income, you would think, well, this person is very securely middle class, maybe even kind of upper middle class. But very often that's because the family has collectively kind of organized to be able to put that person through nursing school. And in return, if she is maybe able to own a house and family members need to be able to stay there with her. And, nurses are often, they're kind of at the apex of a larger family economy. So that's one important piece that kind of complicates the position of the nurse. That was certainly true for many women who managed to kind of scrape together the resources to go to nursing school in the 70s or 80s or 90s, as their husbands or fathers or, other relatives' employment prospects were deteriorating. Second, about nurses, the conditions of work in nursing are always under intense downward pressure. Because nurses are a big cost center for, it's the largest single group of employees that occupationally that a hospital is going to have. And to the extent that nurses can be replaced with other kinds of employees, hospitals would like to do that. And a big way that they have done that, in particular, since the early 1980s and some reforms to the health insurance system that I didn't talk about it, but I do talk about it in the book, is by shortening lengths of stay. And as they shorten lengths of stay, patients who continue to have real need for attention, and they also no longer have, family members who maybe can wait on them hand and foot, they move from the hospital to the nursing home or to a home care situation. And what that does is it replaces the labor of an RN or an LPN with the labor of a nursing assistant or a home health aide, which is cheaper from the perspective of whoever is paying for it, because nurses are more expensive and hospital care is more expensive, but also means that the position of the nurse is being degraded and eroded. And, to some extent, even I would say that process is happening with doctors, although it's more complicated because, the doctor continues to employ more professional kind of, to a significant extent, more professional security than the nurse, right? The doctor is rarely the direct employee of the hospital in the way the nurse is. But doctors are increasingly employees, rather than not necessarily of hospitals, but of different kinds of medical staffing agencies and so on, compared to the role that they used to play. Now, I haven't studied the kind of racial dynamics and dimensions of in particular with doctors. I haven't studied doctors that much at all, to be honest, because I was more interested in kind of working class formation processes. But I would wager that based on kind of anecdotal experience, that in poorer and less white healthcare markets, you find doctors who have been pushed further down the process of losing autonomy and control over their own work. And the reason for that is that poorer markets and less white markets tend to be also less remunerative markets for healthcare corporations, which means that they are going to be looking to cut costs however they can. And to the extent that they can increase their bargaining power vis-a-vis doctors, that's going to be a major way of doing that. So I bet that there is a kind of interesting story there, although it's not one I can give you definitively.
Thank you. We had a raised hand from Edmund Russell. You can go ahead and unmute yourself and ask the question.
Hi, I want to thank you for a fabulous talk. Loved it. Loved the presentation, loved the data, powerful argument. One of the things that struck me is that, so far as I could tell, the trend lines in your graphs have not leveled off, at least at the point when they cut off in time. They're still going up. And as I stared at that, I was wondering how they could continue going up, given that the steel workers with the generous health plans that you describe as the financial infrastructure that makes that employment in the medical system possible, presumably are becoming smaller all the time. They're old, they're sick, and many are probably dying. So I was wondering what enabled employment and medical expenses to continue rising. And I'm wondering if the answer is phase one was generous in Pittsburgh. Phase one was generous steelworker health packages because of the union, and phase two is the Affordable Care Act. Is that the case? Is that how the economics?
That's a significant part of the case. I mean, you're right, I think, to describe a kind of bridge, like the steelworker plan as a kind of transitory connection between, or a phase that doesn't continue in the same way now. And so I think of it as sort of bridging from an earlier moment to a later moment. But what happens as industrial workers bargain these generous benefits is that they, one, change the role of the healthcare system in society more broadly, right? Because they cause these hospitals to grow and grow and grow. And so, even people who aren't steel workers in various ways kind of enjoy some of the kind of enjoy or are hurt by some of the knock-on effects of that in different ways. The hospitals offer more services, they do more things, people rely on them for much more, various kinds of medical and hospital procedures change their shape in response to that market, but then other people also go to those hospitals. So everyone has those long lengths of stay and so on. A good example of this is that Blue Cross of Western Pennsylvania, for all of this period, is able to do what's called community rating, where they assess premiums. Basically they assess risk and then assess premiums at the community level, not at the individual level. So now, when you get insurance, often you are assessed for your individual risks, right? And you're charged accordingly. What have your habits been in various ways? And that was not the case, because even if you were not a steel worker, the presence of this large group of steel workers in this market then enabled Blue Cross to do community rating for the market as a whole. There's other examples like that we can kind of talk about, but the result is that the system is sort of engineered in this particular way, elements of which produce patterns of market behavior, basically, that then non-steel workers also participate in. It's also true, and this I think is what your second question kind of alludes to, that as the system grows, as people begin to use it in ways that are more expansive, either because they have these good packages or they are just going to hospitals that have been engineered in response to these good healthcare packages, costs are going up, and that generates political pressure on the government to find ways of making sure that people who are included who might not be able to kind of collectively bargain such good benefits. That's really the origins of Medicare and Medicaid. The reason Medicare and Medicaid happened in the mid-1960s is it's because there's been a little over a decade at that point of these private sector collectively bargained benefits driving up costs for the elderly and the poor, the people who are not privately wealthy, and also because they're retired or because they don't have good jobs, can't get access through their jobs. And once you have Medicare and Medicaid, to a significant extent, the general phenomenon I've described can happen even without the large group of industrial workers. Now, if you have a group of industrial workers, they speed it along. But once you have Medicare and Medicaid, that will do a lot of the work itself. And in particular, because as people lose good employment, they get pushed into Medicaid at higher numbers. And over the last generation, Medicaid has significantly passed Medicare. It used to be a smaller program than Medicare. It's become a larger program than Medicare. Medicaid, as opposed to Medicare, which is universal for people over 65. The ACA, in turn, accelerated that process. And I think the way to understand that is like an increasingly more unequal society, because of this previous institutional engineering of the role of the healthcare system, came to depend on healthcare to deal with a kind of wider range of social needs that were only partly strictly medical. And Medicaid, as well as Medicare, became important channels for doing that, which then created political pressure to expand Medicaid. And that's where the ACA comes in.
Thank you. I have another question.
Sorry, you said you had another question, Evie?
Yes, I was using the wrong computer. I'm sorry. I have another question from the audience. Patricia?
Hi, I was wondering, I grew up in Homestead, Steel Town, and that was definitely impacted by deindustrialization. But I was wondering if in your studies, if you had come across any information with regard to independent healthcare facilities like the Alma Hillary Health Center in Homewood, which really assisted a lot of African Americans.
Yeah.
At that point in time for impact by low income consumption.
Yeah, that's actually what I was alluding to earlier when I was describing the conflict around Pittsburgh Hospital, because it was Pittsburgh Hospital that wound up basically being forced to support that institution, that health center, as part of the kind of political conflict over the lack of availability of healthcare services in Homewood. And then I now forget all the details, but the political there's struggles over control of the clinic that go into the 80s, I believe, or late 70s, and eventually I think become quite damaging to its functioning because it was dependent on an annual appropriation. And I think this is a really useful illustration of the difference between the different sectors of the working class, which are racialized, as I was sort of talking about at the beginning, right? For people who are in the kind of protected and secured sector, right? If you get healthcare through your job or you get it through retirement, you bring your entitlement to service with you to the doctor or to the hospital, to the clinic, right? You kind of carry it on you. I mean, literally in the form of a card in your wallet. And that implicit kind of guarantee, right? That form of entitlement, as we would call it, becomes the financial basis for hospitals to expand so rapidly. I mean, the period of rapid capital expansion in the 70s and 80s for hospitals is all about the fact that there are enough people who have that kind of guarantee that hospitals know that if they borrow money and build a new wing, they will be able to make their payments. In contrast, for a clinic funded by the poverty program, they have to fight every year to get the money appropriated to keep the doors open, because if economic security is being routed out into the working class, first through industrial employment and second through retirement, and partially through poverty, but in a kind of complicated way, then the people who kind of fall through the cracks of that, who are going to be concentrated in more dispossessed neighborhoods like Homewood, right, which have been economically abandoned and punished in various ways. Service providers in places like that are going to be much more economically vulnerable. And so I think that's the kind of tragedy of that story, which otherwise is kind of a social movement victory at the beginning of it, right? To actually compel the hospital to support the opening of the clinic and then to win community control to a significant degree over the clinic, which they were able to do.
Thank you. Do we have time for any more questions?
Sure.
Okay, we have one more from the audience. Go ahead.
Absolutely enjoyed your presentation and was taken in everything that you were saying. You mentioned somewhat with the first question that was asked about professionals and medical doctors. I was the first African-American female on UPMC's board of directors 23 years ago, 25 years ago. That was extremely interesting, dealing with the janitorial strike straight up through my everyday fight for Black doctors. And why couldn't we get them? We're UPMC. You have enough money to get whoever it is you want to get. Why can't we bring in these Black doctors? Even despite the focus that you shared on your research, I'm just curious if you have any other comments about that thread in the at UPMC or any other hospital. I'm positive it was not just UPMC. It's all
right. Yeah, I appreciate the question. I mean, I think that there's a kind of important story to that. My book tries to tell, but I won't claim to have told exhaustively about the changing economic priorities of hospitals over the last generation, and the consequences of that for whom they employ and to whom they provide services. And I think the basic contour of that story are that since the mid-1980s, increasingly, and the final chapter of my book tries to document this, increasingly, the way that our health insurance system works has been to reward hospitals, in particular academic hospitals, for very technologically and scientifically intensive, complex forms of intervention. So the famous example that probably everyone knows already about Presby is liver transplants, right? But in various ways across the country, academic hospitals in particular, but in general, hospitals that were able to specialize in things like transplantation, cancer, cancer treatment. A big one in more recent years has been spinal surgery and orthopedics of different kinds. Those hospitals increasingly were rewarded for being able to do that kind of business. And the hospitals like, let's say, Homestead Hospital or McKeesport Hospital or Aliquippa Hospital, which specialized in relatively less intensive procedures, were more kind of woven into the fabric of regular, ordinary life. Babies were born there. If someone had a kind of chronic or semi-acute condition, they could they could go to that house, if they had that good insurance, as many of those communities did for a long time, they could go to that hospital and get looked after for a couple of weeks and recover kind of gradually. Now, Homestead Hospital could do that kind of business in the 60s, 70s, into the mid-80s, but starting in the mid-80s and especially into the 90s, that business became totally uneconomical for those hospitals. That's why they all went under, got bought out, and many of them got closed, most infamously Braddock. Now, what exactly that means for who gets hired onto who is on medical staff is not an absolutely straightforward question when we think about the racial composition of who, there are obviously African-American oncologists and orthopedists as well as white ones, but it means from the perspective of hospital management, it seems to me, their market increasingly is not local, right? It's not even regional, it's national and it's global. And to compete on those kinds of markets, what they're interested in is the kinds of doctors who they perceive as having the kind of greatest reputational capital. And those sorts of questions, I mean, in academia, we deal with this all the time. Those sorts of questions get infiltrated by racism very quickly, I think. Right, as a hospital is kind of trying to calculate which kind of doctor is going to bring us the business of, the Saudi royal family, for example, just to kind of come up with an extreme example. It's very easy to see how once that becomes the economic calculus, the kinds of decisions about staffing are going to respond to that.
Close down. Could you say a word more about Local 1199? Because I think Coretta Scott King was an important catalyst of
Yes.
the organization nationally. And I'm wondering how that played out in Pittsburgh, show Jordan your thoughts on the way that movement unfolded here.
Yeah, I appreciate your asking that. I'm glad to talk more about it. So Local 1199 began in New York City in the Great Depression as a pharmacist union. But over the course of the 40s and especially the 50s, the pharmacists managed to figure out how to organize into their organization all of the workers at a couple of hospitals, in particular, starting with a hospital in the Bronx. And as they did that, it was a union whose initial membership had largely been Jewish. Pharmacy was a kind of Jewish business at that point to a significant degree in New York City. But as they did that, they had to figure out how to become themselves a racially integrated organization in a different kind of way, because New York City hospital workers were a lot of West Indian people, African-American, Puerto Rican. And so it was an organization that within the labor movement had spent more time and effort thinking about questions of racial equality and civil rights and integration than most labor unions had done. That's not to say it had a perfect record or something like that. It was not, you know, there was lots of critiques of it internally, and ultimately a lot of, you know, racial strife internally over time, as a largely white leadership presided over the decades over an increasingly Black and Latino, rank and file. But nevertheless, I think it's, you know, credit where due. They did put effort and time and thought and work into trying to figure out what it meant to be a racially integrated trade union in a moment when there were not very many unions doing that kind of work. It's for that reason that Martin Luther King described it as his favorite union. And in the late 60s, 1199 realized that across the country, there were hospital workers who had, you know, like the situation of those workers at Presby, had no representation, were working in conditions that were widely seen as plantation or dictatorship conditions. They'd only become covered by even minimum wage law in the late 1960s. And they realized that the civil rights movement created an opportunity to connect these economic questions to racial justice questions across hospitals across the country, even though there was no legal protection for what they were doing. They did not have the power to compel hospitals to recognize a union through the normal legal process. They had to do it another way. And I really strongly recommend the short film, it's about 25 minutes, called I Am Somebody, about their campaign in Charleston, South Carolina. This is in 1969. A campaign to organize hospital, almost entirely African-American women workers at a hospital in Charleston, which was after Martin Luther King had been killed, but Coretta Scott King became very involved in that campaign because she saw its potential to really connect questions of racial and economic justice and also gender in a central way, right? That these workers were overwhelmingly women also. And so she spent a lot of time on that campaign in Charleston. And although they did not win union recognition, you know, it's very hard to win a union in the South under any circumstances in that period, much less for African-American women outside of legal protections. They did win some significant concessions and felt like it was a kind of a moral victory. And so they launched campaigns across many cities, Philadelphia, Baltimore, Buffalo, and Pittsburgh. And they came to Pittsburgh and essentially tried to run the same strategy that they had run successfully in New York and in Philadelphia and in Baltimore, which was to say that the workers could be kind of organized and agitated around the question of the way their civil rights were being violated every day on the job, right? That there was a kind of structural situation of segregation on the job, not in the sense that they were not allowed to enter public accommodations, but that they did not enjoy the legal protections that white workers enjoyed. And that wasn't officially for racial reasons, but people could see that it was de facto a racial question. So they, you know, their motto was union power, soul power. And it was really a civil rights inspired campaign. It involved it involved sit-ins and civil disobedience. Coretta Scott King was in Pittsburgh along with, you know, a number of kind of prominent civil rights and labor movement activists kind of came to support this effort. But what they found was that one, the hospitals dug their heels in and proved willing, as I said earlier, to, you know, retaliate, to fire people, to get them arrested if they picketed. Two, that actually the Pittsburgh hospital workforce was whiter in its composition than in Baltimore or in Philadelphia or in Charleston for that matter. And the white work, it was still very heavily African-American, but there was a large number of white workers and the white workers would not participate. And so the idea that you could kind of overpower, despite the legal obstacles, you could overpower the hospital administration through civil rights militancy, ran into this problem that a significant portion of the workforce, not a majority, I think, but a significant portion was not interested. And with the barriers as high as they were to doing that without legal protection, the campaign got pulled apart basically piece by piece over the course of 1969, early 1970. But I do want to say one other thing about it, which is that despite workers getting fired, losing their jobs, some getting arrested and failing to win union recognition, they generated enough pressure locally that Pennsylvania in 1970 passed a law, which it was the Public Employee Labor Relations Law. So it was a law to establish collective bargaining for public employees, teachers, municipal employees, and so forth. And in that law, they included private hospital workers, which is a kind of unusual thing, right? Because if you work for Presby, you're not a public employee. Yeah, it's a private employee. But they said in this piece of legislation in 1970, because Presby, or rather because hospitals, excuse me, accept so much public funding every year through Medicare and Medicaid, and Medicaid is the one that the state has power over. So really that was the key one here. They have to deal with how the state thinks that they should operate their businesses. And so we are going to compel them to go through public employee labor relations systems. And that did not prove, that passed. It allowed 1199 and various other hospitals to successfully organize other unions to successfully organize quite a few hospitals around Pennsylvania. They did not ever succeed in really breaking through in the, I think the racial polarization in the workforce was too intense to break through in Pittsburgh after that law was passed. But I think it's worth understanding that even when, a movement like that is defeated, it can have important ripple effects at the level of public policy.
Very much. No, thank you. And again, I want to thank everybody for coming. And, we are so indebted to so many different people that sometimes we miss everybody relevant to our efforts. And I just have to call out a couple of people here who were here and happy to see Chanel Smith, who has been working diligently on all of these issues of diversity, equity, and inclusion, and also Carl Redwood has joined us on the community part. So again, thank you everybody for coming, and thanks again to our speaker. This was an extraordinary presentation. It will fuel our efforts over the next almost a year, 4 years. We're working on these reparations issues, and there is much food for thought inside that presentation. So thanks again, and have a good weekend.
Thank you for having me. I really appreciate the opportunity to talk to you all.